Thank you. So just to give you an overview of what I will discuss today, first I'm going to discuss a little bit about the history of intraperitoneal chemotherapy. I'll address the very limited prospective data for any therapy for appendix cancer, and focus, of course, on the cohort studies that most of the data is based on. And then also the clinical trials for regional therapy for the peritoneum have been exclusively in ovarian and colon cancer. They've been extrapolated to appendix cancer to justify treatments. We'll also discuss those. So appendix cancer is obviously much less common than colon cancer. It tends to occur in younger patients, predominantly mucinous type. There seems to be preponderance of well-differentiated histology, and there are cases of high grade similar to colon cancer. However, very much unlike colon cancer, almost everyone with appendix cancer presents with peritoneal surface metastasis. And it, in many cases, in fact the majority, appears to be minimally invasive, so not truly invading into the organs, unlike the peritoneal metastasis from colorectal cancer. So as a result, the number of operations we do for cytoreductive surgery for appendix cancer is almost the same as for colon cancer. This is a patient of mine with a moderately differentiated appendix cancer who you see his before and after FOLFOX scans. And as you can see, there's really no difference at all. And this is pretty typical for many appendix cancers. It may be due to the predominantly mucinous nature where it's very difficult to assess radiologic response. But given the lack of success with systemic chemotherapy, the regional approach of cytoreductive surgery and intraperitoneal chemotherapy has dominated the treatment of appendix cancer. The goal of cytoreductive surgery is to leave no residual nodule bigger than 2.5 millimeters, because that's the approximate penetration of the IP chemo, and preferably no gross disease at all. Since the early 90s, in the absence of any randomized trials, various protocols for delivering intraperitoneal chemotherapy for peritoneal metastasis for a variety of tumors have been developed. And in general, 5-year survivals in excess of 50% are associated with this approach compared to much poorer for patients who've had suboptimal cytoreductive surgery or palliative surgery only. This is a very heterogeneous, there's a lot of heterogeneity in this disease. And I'm going to address some of those aspects. First of all, the histology is very varied, and it's quite confusing because there's several different grading systems. The typical low grade can also be called well-differentiated, or DPAM, diffuse peritoneal adenomyocinosis. There's an intermediate or moderately differentiated level, as well as the high grade, poorly differentiated, or also called PMCA. And each of these systems appears to stratify patients, and many different hospitals will use different systems, so it can be difficult to compare sometimes. But overall, you can see that the low-grade cancers, this is recurrence-free survival. Low-grade cancers do much, much better than the high-grade or the intermediate grade. And then this is recurrence data from MSK, where you can see recurrence nears 100% for the high grade and is less than 50% for a low grade. This is after cytoreductive surgery. There's also heterogeneity in the burden of disease, and many patients will present with very low volume disease discovered incidentally at the time of another operation for a hernia or a gallbladder or a fertility procedure. But CT and MRI are both inaccurate at estimating peritoneal disease, so for most studies, they report on the intraoperative findings. And the downside with that, of course, is staging at laparotomy is a single point in time. There may be variability in the time to diagnosis, and therefore it's hard to say how early or late a patient's disease is in their natural history. And then there's also huge variations in tumor biology, which are not reflected in the assessment during an operation. But typically we use the scoring system where you can get up to 39 points. The abdomen's divided into 13 regions, and each region is given 0 to 3 points for the extent of disease. And this appears to stratify outcomes. So this is a series from Memorial for appendix cancers, And the patients with high volume disease, you can see, again, almost all recur. Obviously, there's a number of censored patients, but everyone followed to far out enough will recur with high volume disease. However, with low volume disease, you'll see better outcomes. The cytoreductive surgery score is the score that you do at the end of the operation to indicate what residual disease is left. And again, there's a lot of variability in the studies. The study on the left is from Memorial. This is 50 patients with appendix cancer who underwent cytoreductive surgery and EPIC. And you can see that patients with some residual disease had a significantly higher or a significantly higher recurrence than patients who had no gross residual disease at the completion of the operation, and about half fell into each category. This is data from the European randomized trial I'll discuss later, and this actually refers predominantly to colorectal cancer, but again, you can see that the extent of residual disease very much is associated with their survival, and no gross residual disease being by far the best. So to look at the variable types of chemotherapy given, we can look at different centers in different countries, because each center tends to have their preference for how to approach intraperitoneal chemotherapy. So Washington Hospital Center, where Paul Sugarbaker is, and the Netherlands, who predominantly use HIPEC with mitomycin C, we see 5-year survivals of around 40%. France and Australia, they reported combined series of HIPEC and EPIC, also around 40%, and Memorial, that until our recent clinical trial only used EPIC, shows 63%. And these are obviously small numbers, and I don't think there's any meaningful difference between these, so it's very difficult to say that one approach is better than the other based on these single-center experiences. That was for high grade. For low grade, you can see similar, that the ranges are from 64 to 100% survival, similar across these institutions regardless of approach. And so this does not really separate HIPEC versus EPIC. And again, some of these use mitomycin and some use oxaliplatin. This was a rather provocative study reported from Memorial about 10 years ago, where they overlaid the Memorial experience, which was a mixture of patients who underwent palliative surgery as well as cytoreductive surgery, and they overlaid it with Paul Sugarbaker's outcomes for low-grade appendix cancer, who were exclusively treated with the goal of cytoreduction rather than just palliation. And as you can see, there's a complete overlap. But again, all of these retrospective series, the comparisons are unfair because they don't really level the playing field as far as patient selection goes. So the trials of intraperitoneal chemotherapy, the most convincing is in ovarian cancer. There's been 3 GOG randomized trials. The first and third showed an overall survival benefit for adding intraperitoneal chemotherapy after cytoreductive surgery in addition to intravenous chemotherapy. And each trial, this was the second trial where it wasn't a significant difference, but clearly it approached it. And each trial had a different approach to the intraperitoneal chemotherapy, and generally it got more intense as time went on without really seeing any difference in outcome. However, there was much worse toxicity the more intense the intraperitoneal chemotherapy became. So due to toxicity as well as some technical issues, it has not really caught on to the extent that you would expect based on such a dramatic difference in survival. So it's clear from the ovarian cancer data that catheter-based intraperitoneal chemotherapy has an overall survival advantage over intravenous chemo alone in optimally cytoreduced patients. And most likely the toxicity seen with the intraperitoneal chemotherapy relates to the drug dosage and frequency much more than the fact that it's being delivered intraperitoneal. But as I said, intraperitoneal chemotherapy has not been widely adopted, even though it is listed as a standard of care in NCCN. There's perceived technical complexity. Many outpatient chemotherapy centers don't have experience with it and don't feel comfortable giving it. So therefore, there's a lack of infrastructure to deliver it throughout the country. And this, due to the greater toxicity in the experimental arms in those trials, there's a perception that it's more toxic than intravenous chemotherapy. There's been one trial in colorectal cancer. They did include some high-grade appendix cancer, and this was, again, using EPIC, so post-operative catheter-based chemo. It was powered with 90 patients to find a 30% difference in 2-year overall survival. The primary was resected, and they allowed resectable liver metastasis in the series as well. All patients got best systemic for 3 months, followed by optimal surgical cytoreduction, and then randomization to either post-op EPIC with mitomycin and then 5-FU, or 6 months of systemic. And the experimental arm also went on to 6 months of systemic. And unfortunately, it did not accrue. So over 4 years, only accrued 35 patients, and they closed the trial. They did report their outcomes and saw clearly that the two groups overlapped completely, so there isn't even a hint at a benefit. But what was interesting was that the 2-year overall survival is much better than previously reported. The historical data at this time showed survivals without intraperitoneal chemotherapy of significantly less than 2 years. And again, we can't address whether or not this reflects patient selection. And given that all patients underwent an optimal cytoreduction, it's likely that these were the best patients. The development of HIPEC, theoretically, there are disadvantages, or sorry, there are advantages to multiple cycles of EPIC because there can be greater cumulative tumor cell kill than a single cycle, and that's one of the advantages of doing it after surgery with a catheter. However, the GOG studies showed efficacy despite the number of cycles that they had planned. So they looked at, they did some subset analysis looking at the number of cycles that were received. 8 were planned, and many patients only received 1 or 2, and they found no difference in outcome between the patients who received few or many cycles. Multi-cycle EPIC has been proven difficult for many patients to tolerate due to postoperative pain, distension, and nausea, which also discouraged use of EPIC. And as I mentioned, it's logistically challenging. There are few centers who offer it, so patients may have to go a distance to receive it, which can be impractical. Thus, HIPEC was developed. Initially, the intraoperative intraperitoneal chemo was given normothermic, but subsequently intraperitoneal hypothermia was integrated into the treatment paradigm. It's believed to be cytotoxic to carcinoma cells based on in vitro data. And there appears to be increased sensitivity of cancer cells to mitomycin C when heated to approximately 42. So the randomized trial in the Netherlands that I mentioned was of patients, again, predominantly colorectal, but they did include some high-grade appendiceal. They could have either had primary or recurrent disease, no solid organ metastasis, none received induction chemotherapy. They were randomized and either went to surgery with HIPEC followed by 6 months of, at the time, what was best systemic, versus 6 months of best systemic with or without palliative surgery as needed. They randomized 105 patients. This was the chemo-only arm, and it's notable that only 44 out of the 51 even started treatment. Likewise, in the experimental arm, 54 were randomized, 49 actually got HIPEC, and of those, only 33 went on to get their systemic, presumably due to toxicity. But in their initial as well as their longer-term follow-up, they showed a significant difference in overall survival with the they call this the HIPEC group, but it was really surgery plus HIPEC versus standard systemic. There was issues, though. They had what many people consider, including me, an unacceptable perioperative mortality of 8%, as well as a lot of morbidity that's listed here. Now, discussing this with the authors, I think this probably reflects the learning curve. Most institutions, their early experience of 50, 100 patients showed significantly higher mortality than subsequently. Whether that's improvement in surgical technique, better patient selection, we don't know. But in established centers, they don't even come close to this 8% mortality anymore. Interestingly, they stratified based on the extent of cytoreduction and found that a dramatic difference in the outcomes. So the CC0 are the patients with no gross residual disease at the end of the operation, and they had a 4-year median survival. And this is colorectal cancer. This is not low-grade appendix cancer. They also looked at the patients who had minimal residual disease, and they did significantly worse, and the patients who had more than 2.5 millimeter size nodules at the end of the operation did extremely poorly and are really no longer considered appropriate candidates for intraperitoneal chemo. So the conclusion from the Dutch trial was there appears to be a benefit of adding cytoreductive surgery and HIPEC to 5-FU-based therapy. However, we don't know if that applies in the current era where there's a much broader range of systemic options. And major morbidity may be high, and patients should be carefully selected and treated at specialty centers. There was an attempt to do a randomized trial through ACOSOG in the United States. It was a fairly ambitious trial with 310 patients. They had several levels of stratification, followed by randomization to either IV chemo or cytoreductive surgery, HIPEC and IV, basically the same model as the Dutch study, with a crossover for progression. And the primary outcome was overall survival. Unfortunately, it got closed after enrolling only one patient. It appears that it may have been self-defeating, as many patients were offered treatment off trial at places where treatment was being offered on trial as well. Fortunately, there has been one completed randomized trial. This is conducted in France, Protege 7. It's for patients with complete cytoreduction to no gross residual disease, and then they're randomized to HIPEC or they're randomized to HIPEC or no HIPEC, and those results are pending. So we're anxious to see what came of that. They used 30 minutes of oxaliplatin. Oxaliplatin in Europe is much more commonly used for intraperitoneal chemo than it is here. I'm assuming it's because they're not often pre-treated with oxaliplatin, as most of our patients are before they come to surgery. The same group that did Protege had one fairly large comparative study where they looked retrospectively at all their patients treated with intraperitoneal chemotherapy. And again, this is colorectal cancer. All patients had peritoneal disease, and a small number also had liver metastasis. There was about an 84-to-16 ratio of HIPEC to EPIC. Basically, early they were using EPIC, and then they switched to HIPEC. Again, much lower mortality than reported in the Dutch trial, and this has decreased over time as well. A significant amount of grade 3 and grade 4 morbidity, and a fairly long length of stay. The morbidity was very closely associated with the extent of disease, the PCI, that's that scoring index from 0 to 39. So for each additional point, you see the increased odds ratio. And also very closely related to the hospital experience, which reinforces the concept of the learning curve for this treatment. When they looked at survival, there were multiple significant predictors, including the extent of disease, with patients with large volume disease doing very, very poorly. The extent of residual disease, again, with gross residual disease, very poor outcomes. They looked at the type of intraperitoneal chemotherapy, and this is really the only meaningful comparative study we have of these two modalities, and they did not see a difference. And this would have been earlier in their learning curve, so maybe even possibly a little bit biased against EPIC. Presence of positive lymph nodes was also a predictor. They noted that use of oxaliplatin was associated with better outcomes, but this was also a much different era in systemic chemo, so it's hard to know how meaningful that is. And the use of systemic also was associated with better outcome. So to conclude, cytoreductive surgery and intraperitoneal chemotherapy in selected patients has good outcomes, particularly for low-grade appendix cancer, but is very rarely curative, if ever, for high-grade appendix cancer. Overall, the sorts of numbers that we see are 10+ years of median survival in optimally debulked low-grade appendix cancer, but with about a 30% recurrence at 5 years, indicating that even recurrent disease can be associated with a better prognosis than metastatic high-grade appendix, which has about a 4+ year median survival in the optimally debulked setting, but a 60% recurrence at 5 years. We really cannot speak to whether this is tumor biology or treatment effect. There are so many factors that influence outcome, and in the absence of any randomized trial for appendix cancer, we're not going to know whether this is really biology or treatment effect. And we really don't have any data to support one type of intraperitoneal chemotherapy over another. At Memorial and possibly at other centers soon, we have the ICARUS trial, which is intraperitoneal chemotherapy after cytoreductive surgery. It's for patients with colorectal or appendix primary who undergo optimal surgical debulking and then get randomized during surgery, stratified based on recent chemo, as well as whether it's appendix or colon. And we're using 100 minutes of HIPEC with mitomycin C versus EPIC using FUDR through a catheter for 1 cycle on post-op days 1 through 3. Our primary endpoint is 3-year estimated survival, or disease-free survival. We're also looking at treatment toxicity, molecular analysis of tumors, quality of life, and nutrition parameters. For the interest of time, I'll skip over that. We're excluding patients with previous debulking or intraperitoneal chemotherapy, as well as appendix carcinoids. The plan is to randomize 101 patients, and we're anticipating 212 patients at a 1-to-1 ratio, and anticipating 110 events with a median follow-up of 3 years. And we'll have 90% power to detect a 20% difference in the proportion of patients with disease progression or death. And at this point, we've enrolled between 50 and 60 patients. And that is will be open for accrual for several more years, we expect. Thank you.